This has been an interesting saga for me as an orthopedic surgeon. I'm primarily orthopedic surgeon, general practice in Anchorage, Alaska. Born in Anchorage, Alaska. Did a lot of my training out of state. I'm not an industry consultant. I'm not a rock star orthopedic surgeon. I don't work with industry in developing the implants, and to date I haven't been paid to do legal testimony related to this. The work I've done to date has been supported by a generous grant by the hospital that I do most of my work at, which is Providence Alaska Medical Center. It's a real critical part in the study is this team of people here, which these are engineers primarily out of Dartmouth Biomedical Engineering Center in Hanover, New Hampshire. They're basically pathologists for failed joint replacements. And I've been working with these individuals now for 22 years since I've been in private practice. I've always been fascinated with how these devices fail. So even though this story today, the short story is one that started in 2006, actually since 1992 as a total joint surgeon, when I take a failed implant out of a patient, I've been sending it to these bright engineers in training at Dartmouth. And they've been analyzing the materials and the designs and giving me some clue about why these things don't work. This is not a commonly done practice. Probably less than 1% of the implants in the country that fail get an analysis. And you know, I liken it to someone who operates on a tumor and they never send a tissue specimen to the pathologist. It's nuts. The bottom line of my talk here is in total joints, there's been a perverse trend for increased complexity, increased cost, but diminished value and diminished safety. And this is a trend that has occurred across my experience in orthopedics now through training and practice of about 35 years. And in the evolution of total hip replacement, which has really been about a 45-year evolution. And this is a recent report looking at the best data that we have in joint replacement, which is National Total Joint Registry, which conclusively shows that the older implants, which are much less expensive and much simpler, outperform the newer implants, which are much more complex. And if you take a look at total joint replacement, survivorship is everything. And there's been a lot of confusion about this and a lot of marketing saying, well, if you put the hip in through the navel and make it out of kryptonite, people can go back to playing rugby the next day. We don't have any evidence to prove that. What we do have evidence to show is that the implants that were placed in the 1970s, the best of them were highly effective, performed very well, and rarely failed. And what has happened in the past 45 years is we've developed more complex implants that are more expensive and they fail more frequently. And they don't perform any better than the implants that were placed in the 1970s. And the main thing the joint replacement is a wonderful procedure. We take people out of wheelchairs, we restore them to normal active life, but when they fail, it's a very expensive proposition. This is my senior partner, Dr. Declan Nolan, who's a pioneer of orthopedic joint replacement in Alaska, but also a pioneer nationally. When he was a resident at Mayo Clinic, he wrote up their initial 2,000 patients that received Charnley low friction arthroplasties, 1969 through 1971. So monumental work. His initial paper was looking at the short-term complications that they had during hospitalization, DVT, infections, whatnot. There's Declan a few years ago holding a hip that he put in a patient about 40 years ago, and I revised about 5 years ago. This very simple implant gave this woman great function for 30 years. Eventually it did fail, it did loosen, and I had to revise it. But not until after 30 to 35 years of excellent service. That's a very simple device. This is Declan's series now followed out 25 years. Same series has now been followed out more like 35 years. The bottom line is this very simple implant operation performed by resident trainee surgeons had a survivorship far better than what we're doing today, with much more complicated, much more expensive implants. Now, there was concern with the Charnley as we learned about it, that in younger active patients did fail at a higher rate than the geriatric population more suited to joint replacement. And this is really what drove innovations in changing the materials and the design of the implant. And you can see the original Charnley there. Polyethylene socket cemented into the pelvis, one-piece femoral stem made out of stainless steel, relatively small head. And a lot of the things we've done since then have just markedly increased the complexity of the implant. A lot of it to do with trying to make the ball more of an anatomic size, which seems to appeal to surgeons and patients, I think, more from a marketing, almost religious perspective, rather than from a perspective of actually improving the performance of the implant. This is regulation of these devices I'm just beginning to understand it. You have devices like the Charnley, which are predicate devices. Some of them were extraordinarily successful, like the Charnley. Then as they started to regulate the devices, the companies could come to the FDA and say, well, we've made a small change to the device. We haven't fundamentally changed it. And the FDA, through a fairly accelerated process called the 510K, not 501K, could allow that minor change. Or if it was thought to be a revolutionary change that was fundamentally different than a predicate device, then the companies would have to go through a full pre-market approval process, including trials, more similar to what's done with pharmaceuticals. The bottom line is almost every device used today in the United States is a product of the 510K process, not the pre-market approved process, with a few exceptions such as hip resurfacings. What this has led to, and there was a great New England Journal of Medicine article looking at the evolution of these implants. If you do enough small changes over a long period of time, you wind up with devices that have little resemblance to the predicate devices. And again, you see the Charnley device on your left, and you see this is just one device on the right. In fairly common use today, you've gone from 3 materials and 2 parts to 7 parts, 5 junctions, multiple materials, and a totally different bearing. So what fundamentally has happened with all this evolution is the predicate Charnley device, which failed over 5 years in the general population at a rate of about 0.5% per year, or 2 to 3% over 5 years. These newer, more complicated devices, the worst of the worst, like the recalled ASR, metal-on-metal hip, or some of the metal-on-plastic hips that employ modularity, are failing at rates up to 20 times that of 1970s technology. And this takes standard American marketing and turns it on its head. I mean, we just believe that newer is better. We believe that more expensive is better. And in total joints and total hips, we've shown it's well proven not to be true. Metal on metals is how I got involved in this topic, but it turns out you're dealing there with the tip of the iceberg. With these modularity issues, you can also generate metal debris from these taper junctions, which can corrode. So whether it's a metal-on-metal hip or a modern modular hip that has modular cobalt components, you can generate metal debris at the hip, elevated blood cobalt levels, and potentially systemic toxicity. There's an extreme form of this, which is somewhat complex. If you have an original ceramic hip that breaks and it gets redone into a metal-on-plastic hip, ceramic debris becomes embedded in the plastic and wears the head like a cheese grater. And these are patients who can be incredibly sick because of very high cobalt levels. Relatively rare. Then we have the metal-on-metals, where you have abrasive wear of a metal ball on a metal socket, And then you're dealing with a very large population of these taper corrosion patients, probably about 3 million. So all in all, in the United States, we probably have a total population at risk for metal-related hip problems of about 4 million. This is an example of the extreme wear of a chrome cobalt head by ceramic debris. You have extreme metal debris about the hip, tissue damage, failure of the hip, although sometimes not symptomatic. But these patients can be very, very sick, can have serum cobalt levels in the range of 1,000 parts per billion. One death has been reported. Again, this is the canary in the cage extreme failure mechanism. Doesn't happen very often because you need a predicate failure or fracture of a ceramic device, which is then revised. But this is how we learned about the failure mechanisms of the metal-on-metal hips. This is a population at risk of maybe 1,000 patients in the nation. Once you move on to the metal-on-metal hips, you're dealing with an at-risk population of 1 million patients, because over the past 10 years, the metal-on-metal devices became extraordinarily popular to the point we were putting 1 out of 3 hips down in the United States with a metal-on-metal device. This is an example of various metal-on-metal devices, including Dartmouth's CAD demonstration of the wear of my personal ASR, metal-on-metal device, which was the index case of systemic metal poisoning from a metal-on-metal hip. I'm the index patient. I'm also the author of the report, and one of my patients that I put an ASR in is the second patient in that case report. The case report would have never occurred had I not had a prior relationship with Dartmouth Biomedical Engineering Center going back 20 years. Because when my device came out and this mystery of why it failed and why I became sick while my metal levels were very high, had I not had those connections, we would have never known. The frightening thing to me is once our eyes were open to the failure mechanisms of the metal-on-metal devices, we began seeing the same problems in a much larger patient population that have modular metal-on-plastic joints. And this is a recalled Stryker rejuvenant device where they made the neck a whole separate piece. So there were 2 modular junctions, one between the chrome cobalt ball, chrome cobalt neck, and a second one between the chrome cobalt neck and the stem. This is a metal-on-plastic device. It's not a metal-on-metal device. But the corrosion that occurs at these taper junctions appears to be quite toxic to susceptible individuals. And we're seeing the same sort of problems at the hip with fluid collections and tissue damage. And we're seeing the same problems systemically with neurologic problems and heart pathology as we were with the metal-on-metal devices. The only difference is at a much lower blood cobalt level. This is a hip that's not recalled, is not thought to be at risk. This is actually a different manufacturer. There's never been any concern about this particular implant. It's got the same problem that this recalled Stryker rejuvenant hip does. This patient has significant tissue damage at the hip, has elevated blood cobalt levels, not to the same degree as we saw with the metal-on-metals or the ceramic-on-metal wears, but significant toxicity requiring premature expensive revision surgery with all of the risks. And one of the problems we're seeing with the hip problems at the hip is if you lose the ligaments and tendons around the hip, there's a high chance that the revision operation might fail as well because of instability issues. This is another device also made by Stryker, who made the recalled rejuvenant device. This doesn't employ the second modular taper. Very commonly used device. When I called up Stryker and told them about this case, they said, that can't be. This is our most popular device. This gentleman had a subtle presentation. He came on to me for a foot problem. For follow-up, I had been his primary surgeon. We made surveillance radiograph, found severe bone loss. and he'd actually had a pseudotumor pressing on a sciatic nerve and had a laminectomy for that, which was probably not needed. The good news is blood cobalt levels are a good way to screen for this, and that's this fairly simple blood test. No one in this room likely has an elevated blood cobalt level. We see it in industry and people who are exposed to cobalt. We see it in patients with implants. The implants are wearing abnormally at articular surfaces, or if patients are having corrosion. And we're beginning to understand, you can stratify risk based on blood cobalt levels, and we're beginning to associate the level of blood cobalt levels with whether or not patients might experience systemic toxicity. And you can see a fairly large range in cobalt levels reported. When we finally were able to publish a case report of the two cases, myself and my patient, it was a battle. It took a year to get that in the literature. And it gave me some idea of the barriers to publication of work like that. It was bottled up in our most prominent journal behind an editor who had a commercial relationship with the company that made the implant. I was fairly connected as a surgeon with a research interest, and I started working up through the usual channels of communication with the manufacturer of the implant and my professional organization. 3 members of the presidential line of my presidential organization had commercial relationships with companies making devices with metal-on-metal bearings. So I think there's more to this than meets the eye. We have made definite progress in the past 4 years. Presently, as of when my first report came out, there was I think, unprecedented commentary by the presidential line of the American Academy of Orthopedic Surgeons saying, we don't think this is a problem, or if this happens, it's rare. Well, as of January of this year, the same organization and other orthopedic organizations recognize the problem. Metal-on-metals are virtually extinct. But the problem is we put 1 million in, and those patients aren't being systematically followed or screened for the problems. There's a high level of awareness for certain devices, such as the ASR, which have been recalled. There are 90,000 ASRs put in. Those are recalled devices. It's fairly likely those patients are being followed. But the other 900,000 devices have not been recalled. They're no longer being put in. You might call it a silent recall. Many of those patients are not aware they have a metal-on-metal device, or not aware they're at risk for these problems. And a lot of times these patients are asymptomatic at the hip, yet may have significantly elevated blood cobalt levels and might be experiencing systemic toxicity. Or even though they're asymptomatic at the hip, they may be having significant tissue damage at the hip, which may complicate revision surgery. This is what we're learning about the systemic toxicity issues. Is we had 2 medical students working with us over the summer. They did a full literature survey of over 2,000 papers, found all the cases of cobalt poisoning related to total joints. We could sit there and look at the severity of illness and pretty well correlate it with the degree of elevation of blood cobalt and the duration of implantation time. This is our Stryker Rejuvenate series. In our clinic, we did about 70 of these operations. Now, about 5 years out in that series, nearly half of these devices have been revised. These patients have elevated blood cobalt levels of about 1/10 of the magnitude that we saw in the metal-on-metal cases, yet they're having equal symptomatology at the hip and equal systemic toxicity, suggesting that the metal produced by corrosion may be fundamentally more toxic than the metal produced by abrasive wear of metal-on-metal surfaces. Different chemical processes, similar toxicities, and it seems to be driven by whether or not the cobalt gets into the cells. Concern, once we opened our eyes to the taper corrosion problem, I started seeing the problem in patients that did not have the rejuvenant hip. I saw them in other hips with modular taper junctions, which have been in common use for the past 30 years in orthopedics. Probably at a lower level, but this is an unscreened population. And since I've started looking for it, I've been finding it. And that's very concerning to me, because pretty much 95% of the total joints performed in the United States over the past 20 years contain modular chrome cobalt taper junctions. Example of a relatively young woman. She thought she was doing fine with her metal-on-metal hip. Her surgeon thought she was doing fine because they'd see each other socially. How's the hip? Oh, great. You know, I'm so glad you did my hip. This woman, unbeknownst to her surgeon, was having significant neurologic toxicity from elevated cobalt levels. But when you see your orthopedic surgeon socially in the hall of a hospital, you don't discuss your new depression, your new tremor, which makes it hard for you to start IVs. Issues with memory. This is a more extreme case, one of our cases. Gentleman who had bilateral metal-on-metal hips, had his own air service and was a pilot. Developed rampant Parkinson's disease within a year of his first metal-on-metal hip. Did have a family history. Probably was prone to Parkinson's disease. Finally got symptoms at the hip. His blood cobalt level was over 100. Revised the hip. His Parkinson's disease practically went away. Not completely. But we're learning a lot about the nuances of the neurologic and cardiac toxicity. This is again my concern with the taper-generated cobalt. We're seeing the systemic toxicity of neurologic, psychologic, cardiac toxicity at levels that are 1/10 that of the metal-on-metal patients, and more of a subtle presentation of fatigue, early dementia, cognitive difficulties. Very scary case for me. This is my patient. I did these hips. They're non-recalled devices. He presented to me with pseudotumor type symptoms. I was aware of the taper corrosion issue, so I checked his blood cobalt level. It was elevated. I said, you need an echocardiogram because we're seeing subtle cardiac toxicity in these patients. He had an asymptomatic fresh proximal aortic dissection and required complete circulatory arrest, reconstruction of his aorta. He would have undoubtedly died had he not had a screening echocardiogram. This is a more common presentation of just issues at the hip. This is not my patient. He was done out of state. I did his revision surgery. But he has classic subtle symptoms at the hip, rather extraordinary damage to the tissues about the hip. Complex revision surgery of the hip mandated 6 to 7 years after primary hip replacement. This is an example of femoral stems of hip replacement, just showing all the variations in these taper junctions, which have changed markedly through the 510K process over the past 10 years, which probably is what's driving this increased problem with corrosion at the junction between the stem and the chrome cobalt head. And the chrome cobalt heads are the most commonly used heads in hip replacement in this day and age. There's other options where you can avoid this risk, but presently this risk is not commonly accepted among orthopedic surgeons. Probably 90% of the hips done in the United States today employ a modular chrome cobalt head. Thus, the patients that are presently being done in ORs today are at risk for this problem. Large concern for me, being the first reported case of systemic toxicity from cobalt, is the systemic issues. Often we see that in patients that do not have symptoms at the hip. This is actually a pre-market approved device. This is the Birmingham hip resurfacing. Because this went through the pre-market approval process, although this device is failing at much higher rates than the predicate devices like the Charnley, this device remains popular because it's a pre-market approved device. The company can't be sued for it. And the hip resurfacings have been heavily marketed to a younger, more active population. These patients tend to do very well in the first few years. They tell all their buddies, I could go back to water skiing because I had hip resurfacing. Very popular, still commonly done in the United States. These patients are at very high risk for high blood cobalt levels, complications at the hip, and systemic complications. I think what we're learning here is this is just not a metal-on-metal problem. This is a problem where the vast majority of every patient that's had a hip replacement done in the United States over the past 10 years is at risk for periprosthetic metallosis, problems at the hip, and systemic toxicity. Well, how did we get into this fix? I think in retrospect, you can see things clearly in retrospect. Nobody went out to design a bad hip. All these modifications were done with some sort of justification. However, all the modifications had unintended consequences which could not be foreseen. And part of the reason for this is with joint replacement, it takes 5 to 10 years to figure out these problems. Whereas the development and the regulatory cycle is more like 1 to 3 years. And for the 510K process can be as short as 1 year. So we're continually making changes to these devices, and it's only 5 years down the pike that we start to stumble onto these, I call it the killer rabbit for Monty Python fans. No one's laughing, so there's no Monty Python fans in the room. But it's a killer rabbit that comes in and takes a guy's neck off. It's just a bunny. This is what got us into trouble. On the regulatory end, I think we're in bad trouble because as far as the FDA is concerned, I think it's highly favorable to industry. When even before I published my paper, we published in State Epidemiology newsletter about cobalt toxicity. CDC wanted to put that in their national newsletter. The FDA vetoed it. It says medical device, it's our turf, bugger off. And if that had happened, that would have happened in 2010, and we would be many years ahead of where we are now. So the bottom line is, I think we're seeing, I think the metal-on-metals were the tip of the iceberg. We're going to see much the same problems in the majority of hips that have been performed in the United States over the past 10 years because of taper corrosion problems. It's going to generate a large increase in high-risk hip revision surgery, which is very expensive and complication-prone. And what I've seen in a lot of patients around the country, since surgeons aren't aware of this problem, they're revising the hips to devices that also are at risk for the same problem. So we've had metal-on-metal patients get revised to Stryker rejuvenants. So they got the complication of the metal-on-metals, now they're dealing with a taper corrosion problem. I think as far as from a regulatory professional sphere, a big problem is there's now huge overlaps. The same guys who are developing the devices are the officers in the American Academy of Orthopedic Surgeons. They're the professors. They're being paid millions of dollars to work with industry to develop the devices. It's not like they're overtly corrupt. It's just it's hard to see difficulties and flaws in your own baby. How do we fix this? It's really going to be difficult. But I think the way we fix this relatively inexpensively is to proactively study our failures. That's what we've been, it's what I've attempted to do in my practice over the past 22 years. It's what's led to identification of 3 major issues to date with total hip materials and designs. It's not terribly expensive. My research has been entirely on a shoestring. And for that matter, Dartmouth's research has been pretty much on a shoestring. The entire operational budget for their operation is peanuts compared to what a design surgeon is paid for their work on a new device. Again, I think this is a huge perverse problem. It's incredibly expensive. And I think understanding fundamentally that it's kind of the commercial nature of medicine that has driven this, and it has kind of permeated the professional mores and the regulatory mores, gives us the understanding that it's going to be incredibly difficult to reverse and correct. Thanks for your attention.